Assalamualaikum warahmatullahi wabarakatuh, and a very good afternoon to all of you. Okay, let's say you work in the middle of night and suddenly you get the admission from emergency department. 60 years old man admitted with severe jaundice. So what are you going to do? Severe jaundice. Okay. Jaundice can presented with several presentations. They can be just asymptomatic, just presented with yellowish discoloration without any symptoms, or they can come with fever, abdominal pain, altered sensorium, bleeding tendency, all those kinds of complications of jaundice. Okay, today I'm going to discuss about managing the severe obstructive jaundice. So basically, only jaundice with complications are going to get admitted. Otherwise, they will be referred to clinic and will be dealt accordingly. Because there will be time to investigate, to find the cause, and to investigate for the problems and management. So all patients admitted in the middle of night, early morning, usually they come with problems. So just pick one scenario: obstructive jaundice. Obstructive jaundice means any obstruction in the biliary tree causing jaundice. So when you have obstructive jaundice, severe obstructive jaundice means bilirubin will be high, 150, 200, 250, 300. Usually they will come with some form of complications. So what are the complications of obstructive jaundice? They can be severely dehydrated. Severely dehydrated. They can also come with signs and symptoms of ascending cholangitis, means that Charcot triads, intermittent jaundice, intermittent right hypochondriac pain, and intermittent fever. Or they can come with coagulopathy. Okay, coagulopathy means severe jaundice with evidence of prolonged bleeding, spontaneous bleeding at the gums, PR bleeding, petechiae, rashes all over. They can come with acute renal failure, and they can also come with later stage of complicated jaundice such as altered sensorium in hepatic encephalopathy. Okay, so when this type of patient admitted to the ward as a junior doctors, or junior medical officers, what is your role? Okay, what is your role? So don't get panic. Nobody asks you to do CT scan in the middle of night. Nobody want to do operation in the middle of night. So the management of severe jaundice can be divided into first 24 hours, managing the what we call that resuscitation phase. Okay, resuscitation phase. You don't want to manage to find the cause. You don't want to operate. You don't want to do RCP. Okay, what you need to do is to resuscitate the patients. So the first 24 hours, 24 to 48 hours is just to resuscitate the patient, so that patient will not go into the complicated stage. So I mentioned just now, obstructive jaundice, they can have complications, mainly ascending cholangitis, coagulopathy, hepatorenal syndrome, acute renal shutdowns, severe dehydrations, and later stage hepatic encephalopathy. So you want to prevent your patients from collapse from these complications. So as a junior doctors, what you need to do? So you have to clerk the case as normal, get the very detail of histories, and then assess the patient. The first and foremost, assess the general examination. Apart from jaundice, whether the patient pale or not. On general examination, look for signs of dehydration. On history, ask for the urine output. Okay, and then assess the patients. So from the clinical examination, you can assess the patients whether the patient is severely dehydrated or whether the patient have the symptoms and signs of ascending cholangitis, whether the patient have any evidence of coagulopathy, petty spider nevi, and all those things. And you can also, the patient come with bad odor and then altered sensory, you know this patient is going into dead hepatic encephalopathy. So you want to get all these things. So your job that I mentioned just now is resuscitation. So you need to monitor if patient is severe, you monitor the urine output. So if patient is cannot take care of himself, very dehydrated, very weak, put in the CBD, monitor the urine output, okay? And then put in the IV drips, put in the IV drips. So with this, you can monitor the urine output where we want minimum 50 cc per hour, 0.5 mils per kilo, 30 to 50 cc per hour. And then you put in the IV drips. And before that, I assume you have taken all the blood investigation, the blood urea, hepatitis screenings, prothrombin times, liver function tests. And while waiting for that, you can put it IV drip and CBD. This is the first thing, okay? And if the patient have any evidence of coagulopathy from the history or from the examination, you can give prophylactic IV vitamin K. And when the PT, APTT results come back, if it is prolonged, we can give plasma, fresh frozen plasma. Okay, that is one thing. If it is PT, APTT normal, you want to monitor the patient is old, aging. If you give fluid too much, patient will become overload. So if PT, APTT normal, you can put in long line or central lines, and you can give the fluids according to the CVP reading. So you are safe. You are not putting the patient at risk of developing heart failure or overload. So that are a few things you can do. Put in CVD, monitor input and output, put in the IV drips, and look for the coagulopathy. And if patient having fever and you're having best examination suggested patient have ascending cholangitis, means tender on the right hypochondrium, severe jaundice and fever, and the white cell count came back high. So these are evidence of ascending cholangitis. Do septic workup and start patient on antibiotics. Start patient on antibiotics. So for that, one day from the middle of night till the next morning, these are the things that you will do. Resuscitation mean you will make sure patient will not go into acute renal failure. So adequate hydrations, because high bilirubin will lead to severe renal failure if you are not top up properly the fluids. And ascending cholangitis, you already do all the needs antibiotic first. Bleeding, coagulopathy, or if not, let's say patient is, you give this prophylaxis, make sure PT normal, you are actually preparing patient if patient need to undergo emergency ERCP the next day. Okay, so that the whole night is all about resuscitation. Okay, second part of the management is managing the cost. So after you have resuscitated the patients, then patient is well, you already control the patient from going to sepsis and all complications, you will investigate the cause. So do simple thing, ultrasound, get this hepatitis. When the hepatitis can cause, jaundice. There are medical causes of jaundice. Hepatitis. Ask properly about the drug histories. Ask whether the patient have taken traditional medications. Because some drugs can cause jaundice. Some drugs like what you call antihypertensive can cause liver failure. Sometimes the immunosuppressive therapy also can cause the traditional medication can cause liver failure. Even paracetamol also can cause liver failure. Dengue patient also can present with dengue hepatitis. So do hepatitis screening and get all the other causes. And then we do ultrasound. So ultrasound, if it is obstructive jaundice secondary to surgical cause, they will measure the size of common hepatic duct, common bile duct, any evidence of stones or not, any irregularity in the pancreas or not. Pancreas is not clearly seen by ultrasound. You don't see ultrasound, any evidence of stone, but there is dilated CBD. We will proceed with CT scan. Okay, we will proceed with CT scan because pancreatic tumor always come late after 60, 65. So it's not well seen by ultrasound because of obscured by bowel gas. Then we will deal with that later. Okay. So for example, if it is tumor, CA head of pancreas, periampullary CA, and then we investigate for the fitness of the patient, staging of the disease, and the patient can undergo surgery or not. If it is stones, and then patient is having ascending cholangitis, so there is a role of drainage, either by ERCP or by ATBD. And these are the things. Alright, these are the things that you have to look into it. These very short things for those who get the patient in the middle of the night of obstructive jaundice. Don't worry about CT scan, don't worry about ERCP. What you need to do is simple resuscitation, keep patients safe from going into complications. Like I mentioned, look for evidence of severe dehydration, acute renal failure, hepatorenal syndrome. Look for any evidence of septicemia, ascending cholangitis. Look for any evidence of coagulopathy, and look for evidence of hepatic encephalopathy. Okay, thank you very much for listening.